Hello, welcome to Pneumonia Part 1. In this section, we'll discuss how to classify pneumonia. We'll also discuss the signs and symptoms of pneumonia. Pneumonia is defined as the inflammation of the lung parenchyma. In pneumonia, the alveolar air spaces are filled with exudate and inflammatory cells. It can be caused by infection in most of the cases. It can also be caused by other reasons such as chemical exposure. In this segment, we'll be most interested in infectious causes of pneumonia. We want to know about pneumonia because it kills. Out of all the patients who have pneumococcal pneumonia with bacteremia, the mortality rate is 1 in 5. The older the patient, the higher the mortality rate. In terms of classification, the two broad classification has to do with the patient and the setting from which they acquire their pneumonia. We'll talk about each of them. First, we want to know something about our patient, whether they're healthy or whether they have any comorbidities. The comorbidities are separated into conditions that make them more prone to infection. That can include a list of different conditions, such as diabetes, HIV infection. Medications include anti-rejection medications, steroids, and so on. Other comorbidities we care about also include existing lung problems, such as COPD and asthma. Lastly, we want to know if the patient is at higher risk for aspiration. Those patients includes those with neurological conditions such as seizures and strokes. Knowing who the patient is important since the organisms infecting the patient will be different based on what the patient is like. The second part of the equation has to do with the setting. The setting means where did the patient acquire this pneumonia? Broadly, it is divided into community acquired, that means patients live independently in their own home, and they're not subjected to other people who are sick. Hospital acquired, which means the patient picks up the infection from a hospital setting. And lastly, healthcare acquired. These are patients who are living in long-term healthcare facilities such as nursing homes. Knowing both the patient and the setting will help us decipher which organisms are involved to cause their pneumonia. The categories of the organisms include bacteria. They can be gram-positive, gram-negative, or anaerobes, virus, and rarely fungal. We will focus our discussion on mostly bacterial and viral pneumonia. Let's talk about our most basic patient, a healthy patient who comes from home, who lives independently, so a community-acquired pneumonia. It can be by bacteria or virus. Bacteria infection is divided into typical or atypical bacteria. Typicals are the ones that give the most typical signs and symptoms, which we'll discuss further. The bacteria include Strep pneumoniae, Moraxella catarrhalis, and Haemophilus influenza, or H. flu for short. Of the three typical, Strep pneumonia is the most common cause of community-acquired pneumonia that is typical. In terms of atypical organisms, they can include Mycoplasma and Chlamydia. These organisms do not give the typical signs and symptoms of pneumonia. For viral infection, multiple viruses can cause pneumonia, including the influenza virus and RSV. Virus infections often come in epidemics. Patients who have been infected by a viral pneumonia can also have bacterial pneumonia as well. What about patients with community-acquired pneumonia who have a comorbidity? They are also subjected to all the organisms we talked about before. However, their comorbidities might mean that they are either more susceptible to infection in general or they're more susceptible to certain organisms. For patients who are immunosuppressed, it depends on why they're immunosuppressed. Patients with HIV are more likely to get PCP pneumonia and TB. Those without a spleen are more susceptible to encapsulated organisms such as strep. Those who are immunosuppressed because of medications such as chemotherapy drugs, steroids, are more likely and more susceptible to general infection. In patients with underlying lung diseases, they are more likely to get infection generally. They are also more likely to undergo multiple courses of antibiotics frequently. Therefore, we're much more worried about drug-resistant organisms in them. Lastly, for the patient who have increased aspiration risks, since the aspirate is from the GI tract, we're worried about anaerobes, such as Klebsiella and Fusobacterium. Next, we'll talk about hospital and healthcare-acquired pneumonia. It is defined by a pneumonia that occurs more than 48 hours after hospital admission. It is also known as nosocomial pneumonia. The most common cause for nosocomial pneumonia is bacteria. These bacteria include Pseudomonas, Klebsiella, E. coli, Staph aureus, and in particular, methicillin-resistant Staph aureus. It can also be from Streptococcal pneumoniae and H. flu, which are the two bacteria we have already seen with community-acquired pneumonia. Depending on whether there is a viral infection outbreak, sometimes we do see viral causes such as influenza as the cause for nosocomial pneumonia. How do patients with pneumonia present? We'll divide this into typical and atypical presentation. In patients with typical pneumonia, they will present with fever, cough, tachypnea, and sputum production. On exam, they are usually tachycardic and may be in respiratory distress. They might be confused. On your respiratory exam, you may hear adventitious sounds, such as crackles, rales, rhonchi, or wheezes. There might be decreased breath sounds and dullness to percussion. If there is a pleural effusion, you may also hear pleural friction rub. Patients can also present with atypical symptoms, particularly if they're at the extremes of age, the very old or the very young. They can present with mental status changes, dyspnea, or shock. They may not give you the history of fever, cough, or sputum production. In summary, we discuss a bit of an approach to patients with pneumonia. To figure out what organisms might be causing the pneumonia, we want to start with the patient. Is he healthy? Or are there comorbidities? If so, what are they? Next, we decide on the setting that the patient could have contracted the pneumonia. Is it their own home, a hospital setting, or healthcare facility setting? From these factors, we will be able to best decide what organism is causing the pneumonia. We also talked about the typical symptoms and the atypical symptoms that patients with pneumonia might present with. In the next section, we will discuss how to diagnose and treat the patients with pneumonia. Thank you for watching. Welcome back to Pneumonia Part 2. In this part, we'll discuss how to diagnose a pneumonia and how to treat it. The diagnosis can consist of labs and imaging. Of the two, imaging is the most helpful. We do often do labs in these patients. In patients with pneumonia, we expect their white blood cell count to go up, together with their neutrophils. We also expect their platelet to go up as part of an acute phase reaction. In terms of their electrolytes, sicker patients might have hyponatremia. They may also be acidotic. They might have impaired renal function. Sometimes an ABG is done in patient with respiratory failure. In the well-looking patients, an ABG is not necessary. Imaging is key for diagnosis of pneumonia. The imaging of choice here is a chest X-ray. If the patient is too sick to leave the department, we can just start with a portable chest X-ray. If they're well enough to leave, then we do 2 views of the chest. Let's look at what an X-ray would look like in the patient with pneumonia. In this patient with a portable chest X-ray, could you tell where the infiltrate is? The infiltrate is on the right side of the lung, in the right upper lobe. This is typical of a right upper lobe pneumonia. What about this chest X-ray? Can you see where the infiltrate is? It's also on the right side, but this time it's on the right middle lobe. This is a right middle lobe pneumonia. If you're interested in learning how to read chest x-ray, I've included a resource on the blog. Let's move on to treatment. As with all emergency department patients, we would like to start with ABC. Then we'll delve into specific treatment for pneumonia, and then we'll decide who can go home and who need to stay in the hospital. First, ABC. If the patient is not protecting their airway or if they're in significant respiratory distress, we may have to intubate them. For B, what if the patient is hypoxic? We will give them supplemental oxygen. What about for circulation? What if the patient is hypotensive or tachycardic? We need to give them IV fluids. Crystalloids such as normal saline and Ringer's lactates are both good choices. Once the patient is more stabilized, we can move on to more specific therapy, in this case, antibiotics. In the previous video, we discussed that the organism responsible for the pneumonia has to depend on both the patient and the setting that they get their pneumonia from. We will follow that classification when we discuss the antibiotic choices. Keep in mind that the choice of antibiotics will depend on what your local prevalence and resistance organisms are. And therefore, even though we'll be discussing some specific antibiotics, it is best to check with your local consultants. First, the healthy patient who has a community-acquired pneumonia, or CAP for short. In the healthy patient, a macrolide or doxycycline are good choices. We can also consider IV antibiotics for the patients who are sicker. Either IV ceftriaxone and a macrolide. IV fluoroquinolone is also a good choice. What about the community-acquired pneumonia patient with a comorbidity? If their comorbidity is general immunosuppression, then the IV form of antibiotics that we just talked about, i.e. fluoroquinolones or ceftriaxone plus macrolides, would be good choices. In the patients with COPD, the same regimen would also work. In patients with HIV that we're worried about PCP pneumonia, trimethoprim sulfamethoxazole is a good choice. In patients who have an aspiration pneumonia, we want to target anaerobes. Clindamycin is often used. In those who have had a healthcare or hospital-acquired pneumonia, since they can have much more different bacteria, we need to go broader and stronger in terms of antibiotics coverage. Suitable regimen include, again, ceftriaxone, fluoroquinolones, and vancomycin if we were suspecting methicillin-resistant Staph aureus. These are just examples of regimen you may choose to use here. Depending on your institution, you may be choosing different drugs. For viral pneumonia, it is often in the context of a pandemic. You should refer to the local guidelines at that time to see whether you should be using antivirals or not. The next part is risk stratification. That is, who should be admitted, who can go home, and who should be admitted in the ICU. There are two very helpful tools that help us decide. The first one is called CURB-65, and the other one is called the Pneumonia Severity Index. On the blog, under Other Resources, you will see both of these discussed in details by other sites. We'll first talk about CURB-65. This score uses 5 risk factors to see the overall risk of death at 30 days. The more number of risk factors, the higher the risk. It stands for confusion, urea more than 7 millimoles per liter. The R stands for a respiratory rate more than 30 per minute. B stands for blood pressure, either a systolic less than 90 or a diastolic less than 60. 65 stands for age greater or equal to 65 years old. Each score is given 1 point. The higher the number of points, the higher the risk of mortality at 30 days. Patients with the score of 5 has an almost 60% chance of death at 30 days. For patients with a score of 0 to 1, they're usually treated as an outpatient. A patient with a score of 4 to 5 needs hospitalization. They might need the ICU. For those with a score of 2 to 3, they can consider a very short stay in the hospital unless they have very close follow-up as an outpatient. Another rule is known as the Pneumonia Severity Index, or the PORT score. Again, this is also a risk stratification tool to decide for mortality and morbidity in the patients with pneumonia. It uses a lot of data points to calculate the overall score, including their age, gender, whether they're from a nursing home, comorbidities such as cancer, liver disease, congestive heart failure, or history of cerebral vascular disease. On the physical examination, it looks for altered mental status, increased heart rate, increased rest rate, hypotension, and a high or low temperature. It also draws in multiple lab and radiological findings. Similar to the Curve 65 score, the higher the number, the higher the 30-day mortality. We won't go through each single item here, but I will refer you back to the blog for the other resources that discuss this tool. In summary, we discussed the diagnosis and treatment of pneumonia. We know that the diagnosis hinges on a chest X-ray. For treatment, we always start with ABC for the emergency patient. Once the patient is stabilized, we will also give them antibiotics. The choice of the antibiotics will depend on who the patient is and where the setting that they have acquired their pneumonia from. Lastly, we also discussed 2 risk stratification tools that will help us decide whether the patient can be treated as an outpatient or should be admitted. We hope you find this useful. Thank you for watching.
Almost all child deaths in low-income countries are caused by 3 very dangerous illnesses. Pneumonia, which is a serious chest infection, diarrhea, which is loose stools, and malaria, which is caught from mosquito bites. This film will help you understand when your child is very ill and in need of urgent medical attention. Here's our expert to explain more.
Children of all ages are at risk of severe illness which can lead to death. If you notice any of the following signs, you must immediately take your child to a health worker. The signs that you need to look for are difficulty in breathing, no interest in drinking or breastfeeding, vomiting, a dry mouth and cracked lips, very high or very low temperature. For example, does your child feel much hotter or colder than normal? Pale skin, blue lips, irritable or upset behavior, unusual sleeping patterns, unconsciousness, which is when your child cannot be woken up, fitting, or violent shaking of the body and limbs or arms and legs.
My baby had blue lips and I didn't know that this is a problem. The community health worker told me to go to the hospital.
My daughter didn't do breastfeed. It was unusual for her, but I didn't know it was dangerous.
If your child has any of these signs, you must immediately take them to a health worker. And remember, even if you think your child is ill, then you must keep giving her fluids such as breast milk or other safe fluids like cooled boiled water. If she feels cold, wrap her so she is warm. But if she feels very hot, don't wrap her at all.
So now we understand the signs of serious ill health in the child. We're ready to learn more about pneumonia. This is a very serious chest infection which makes a child cough and have difficulty breathing. The infection can spread through the body and cause the child to die. Here's our experts to explain the warning signs and symptoms of pneumonia.
Check to see if your child is breathing much faster than usual, or if her chest is moving inwards when she breathes, which is called sucking in. Another sign of pneumonia is nasal flaring, which is when the child breathes in and the nostrils flare outwards. You should also listen for any unusual noises your child might make when having difficulty with her breathing. Many children with pneumonia will make a noise like this when they breathe out. This is called grunting. If you hear this noise when she breathes out, take your child straight away to get medical help. Your child might make this noise if she's having breathing difficulties. This is called stridor. Or like this sound, which is called wheezing. These sounds do not always indicate pneumonia, but they are still very serious problems, and you must take your child to a health worker or nearest health post at once.
Now we know the signs and symptoms of pneumonia, let's learn how to treat it.
Drugs called antibiotics are used to treat pneumonia and make your child well again. It is very important that you give your child the exact number of antibiotic tablets the health worker prescribes and for the exact number of days she instructs until the packet is finished. Otherwise, the pneumonia may return. And if your child's condition gets worse during or after the treatment, you must take her back to the health post.
How can we reduce the risk of getting pneumonia and other breathing infections or difficulties? Let's find out more.
Breastfeeding your child for as long as you can may help to reduce the risk of a child developing pneumonia. This is because the mother's milk helps improve your child's protection against many illnesses. Vaccinations will greatly reduce the risk of your child catching pneumonia, so please ensure she has her vaccines and immunizations on time. Washing your hands with soap and water before handling your baby, especially if you have been with another person's baby, will help prevent germs that can lead to pneumonia. Keeping your child away from people who smoke cigarettes will keep her lungs strong and healthy. And finally, try to cook outside, or if you have to cook inside, then keep your child away from the smoke.
So now we know how to check for the symptoms of pneumonia, treat the condition, and most importantly, prevent getting it in the first place. With this information, we can help keep our children in good health.
Hello YouTube and newsletter subscribers, this is Terrell from Terrell03.com. Today is October 31st, 2016. This is not a Black Star update report. The sad reality is finally gaining my attention from concern with my friends and my family that there's something wrong with me, and it's been wrong with me for over a month now. And I've been in denial about it, trying to keep up with the work and everything. It's been too busy to worry about myself, and the stuff that's coming up and the color and the concern finally made me realize that I'm walking around with walking pneumonia. And antibiotics for me, going to doctors, antibiotics, I don't have a doctor, out of the question, not doing that. But there's something that I'm going to try here, reverse pneumonia in 3 hours. And Dr. Andrew Saul. This looks like good information. This is what Nighthawk told me when this happened to me in previous years. High doses of vitamin C. And we're talking 2,000 milligrams every 6 minutes. That sounds like a lot, but I have a big bottle of vitamin C here, and that's the plan. That's what I'm planning to do. Whether it's going to happen in 3 hours or not, we're going to see. And especially if there's good results by the end of the day, because this has been hounding me for quite some time. And I will make a report and let you guys, or at least make a comment in the description box of this video, and let you know how it's going. So be patient with me a little bit. I may need to get more rest and slow down just a little bit here for a little while, get my health back in order, and stop walking around so much like a zombie and with all this hacking and coughing stuff that I've been doing. So just want to make a little video and let you know what's going on. If my replies are a little slower here for a little while, then that's kind of what's going on. Please be patient, and this will pass, and then I'll get caught up, and everything should be okay. So thanks again for your support, and I will see you on the next Black Star update report.
Move over vitamin C. Pneumonia's got a powerful new adversary that may just blow you away how effective it is against Streptococcus pneumonia. Now keep in mind, this is a natural form of vitamin E. I'm going to read you the citation first so you can find the information to validate what I'm saying. Then I'm going to read you the general press release title. So bear with me on the technicality of the first citation as I read it to you. The alpha-tocopherol form of vitamin E reverses age-associated susceptibility to Streptococcus pneumonia lung infection by modulating pulmonary neutrophil recruitment, published in the Journal of Immunology, December 15, 2014. Now the little easier title, the general press release title. Extra vitamin E protected older mice from getting common type of pneumonia. This didn't just protect them, I mean, it blew it away. Now keep in mind, this is natural vitamin E. This is what you see, this little symbol, that means alpha-tocopherol. A lot of parts of vitamin E, but alpha is one part, but it's a natural form. They didn't do the study on synthetic, and they didn't do the study on any other isomers of vitamin E. So keep in mind, it was done on the natural form of alpha-tocopherol. Now I proceed. The researchers had a clue that vitamin E may help boost the immune system. And this is why they looked at this, and this is where it led. Earlier studies have shown that vitamin E can help regulate the aging body's immune system, as opposed to what you hear on the TV news. But our present research is the first study to demonstrate that dietary vitamin E regulates neutrophil entry into the lungs in mice, meaning they know vitamin E helps protect the lungs, but they didn't know how well it did. As I continue forward, and so dramatically reduces inflammation and helps fight off infection by this common type of bacteria, Streptococcus pneumonia. And this is what they did. Aged mice were fed a controlled diet were exquisitely more susceptible. Meaning the controlled diet, meaning the mice didn't get very much vitamin E. Basically like the general population of the United States or the average human. So the ones that just got the regular daily requirement of vitamin E were extremely susceptible to pneumonia, much more than young mice. At 2 days post-infection, aged mice suffered 1,000 higher pulmonary bacterial burden, 2.2-fold or higher levels of neutrophil recruitment to the lungs, and a 2.25-fold higher rate of lethal septicemia. Now, for the mice that got a little extra vitamin E, about 10 times the recommended daily allowance for human, otherwise known as 200 IUs of natural vitamin E. This is what happened to that little extra vitamin E in the diets of these animals. Strikingly, alpha-tocopherol supplementation of aged mice resulted in a 1,000-fold lower bacterial lung burden and full control of infection. Repeat it, 1,000-fold lower bacterial burden and full control of infection. That's just vitamin E. That's not some weird drug or pharmaceutical. That's just simple dietary natural vitamin E. Now to proceed forward. The older mice fed a diet containing extra amounts of vitamin E, the equivalent of about 200 IUs a day of natural vitamin E, consumed by humans, or about 10 times the recommended daily allowance, but well below the upper limit, were far more resistant to the bacteria than older mice that had a normal amount of vitamin E in their diet. And to reiterate and conclude, compared to the mice that had normal amounts of vitamin E, typical RDA, in the diet, the mice fed extra vitamin E, 200 IUs around there, 1,000 times fewer bacteria in the lungs, 2 times fewer the number of white blood cell neutrophils. Reason? The reduced numbers of bacteria and white blood cells resulted in less lung damage. So they need all those white blood cells because the vitamin E was protecting the lungs. In the older mice who received extra vitamin E, These mice were able to control the infection as efficiently as young mice. So, if you want to hedge your bet against pneumonia, and this study in animals does translate, or I should say, it should translate to the same in humans, man, just 200 IUs of extra natural vitamin E could go a long way. So pneumonia has a new adversary, natural vitamin E. Ralph Turchiano, signing off once again.
Spell pneumonia.
Neimonia.
Pneumonia. What if I were to tell you there was a P in the word pneumonia?
Oh.